We'll get going since we have a full agenda. My name is Bridget Walsh. I am Senior Policy Analyst at the Schuyler Center in Albany, New York, and with the New York State Oral Health Coalition. And I'm on the NEMA ROHCT. And so I'm happy to welcome you here today to this final meeting. And something just happened. There we go. So as you know, the ROHCT provides an opportunity to discuss barriers and solutions, hear innovations from other states, and to connect across regions. So we're going to drop, Bianca's going to drop the agenda for today's meeting in the chat. There you go. There's our agenda for today. And since this is our final ROHCT call for 2023, we'd like to take a minute to celebrate all the hard work you've put in this year and all your successes. So in the chat, we'll have you introduce yourself, your state, and one success that you've had in 2023. It could be an oral health success, something you've done. It could be a personal success, because those are always need to be celebrated as well. So drop those in and we can get a sense of what people feel is their important celebration for this year. And we're also going to share in the chat the key themes and trends from the 2023 ROHCT conversations we've had this year. And this document gives you an overview of all the conversations we've had and the resources that we've shared over the course of the year. And so I encourage you to take a few minutes to look at this, either during the meeting or after the meeting, save it for yourself, and take a look at all the important work that we've done together this year. And there's lots and lots of resources in there that you can use for your work and reshare. So the overall theme of today's meeting is what kind of support can we give to each other to advance our oral health equity efforts? So this is a meeting where you're going to be hearing from a lot of people, but it's also a little bit participatory as well, since we want you to share in the chat resources and ideas that you have as the meeting goes on. So we want to figure out how to get messages across to move the needle on some of these efforts, and how do we support getting support from the states that have done some of the things that we're talking about and have eliminated some of those barriers. And then we also want to be thinking about, for states where some of these things are going to be opposed, how can Open and the members of Open support action plans to advance the efforts that you're trying to do, including ideas about messaging, the types of resources we can share with each other, ideas for non-traditional partnership opportunities. So our desired outcomes for today is, by the end of this call, we will have an overview of the AHECs and resources for dental career pipelines, an overview of the dentist and dental hygiene compacts that I know we've all talked about during this year. So more information on that and how to support advancing efforts in your state. An overview of national Medicaid provider enrollment. I know we've all talked about workforce, and this has been an important piece for many of the conversations for supporting expanding Medicaid in your state. An opportunity to ask questions of the experts and dialogue with both state and grassroots representatives from around the country. And so we're going to focus on the who, what, and how we can support each other. So feel free to drop that into the chat at any time. Links to resources you have, offers that you can make to the ROHCT and others about how you can support their efforts and things that you can do for people. So a little bit of housekeeping before we get started. Please make sure you're muted during the presentation, and you will have a chance to come off mute and ask questions at the end of each of the presentations. And you're, again, encouraged to share your thoughts and resources you have in the chat during the conversation. So with that, I am going to turn it over to Celeste to begin the conversation today.
Well, thank you, Bridget. That was awesome. I'm so glad to be here with the Open Network again, serving with the Southeast regional leads. And today we will be hearing from some presentations on the topics that Bridget just mentioned. So we'll be hearing from a few experts in the field, and we welcome you to ask questions in the chat and highlight any takeaways, key takeaways, as well as share any related resources and reports. The resources shared will be put together in a final document to come back to you with today's meeting recording. And to kick us off, please welcome our first presenter, Katie Klukerk. She is a fellow Open State Representative serving as South Central Montana Area Health Education Director, and she's joining us from Helena, Montana. So in the chat, again, we would like for you to add your questions, highlight any takeaways, and share related resources and reports, and keep building those connections with your fellow ROHCT members. Take it away, Katie.
Thank you so much for the introduction. Should I go ahead and share my own screen? Perfect. Okay, and Francis clicking that shared sound. Good. All right, can everyone see my screen okay? Wonderful. Well, thank you so much for having me today. My name is Katie Klukert, and as mentioned, I'm currently the South Central Montana Area Health Education Center Director. They definitely don't make our titles easy around here. But a little bit of background on myself. I'm actually a registered dental hygienist. I practiced clinically for about 6 years before I earned my Master of Science in Dental Hygiene degree, which introduced me to a lot of different career paths, kind of outside that clinical practice aspect. Right after I graduated, the position to manage the oral health program for the state of Montana became open. So I went ahead and took the leap over outside of clinical practice into public health. And to be honest, public health wasn't a career path that I ever really thought for myself until I looked at that position and looked what it entailed, and I ended up really loving it. When I was at the state of Montana in the oral health program, I had the opportunity to serve as the state representative for the Open Network and really kind of get my feet under me and what this network is and all the wonderful resources that you all provide. So when I transitioned to the Montana Hospital Association, kind of again got my feet under me and then started to see a lot of opportunity for, even though I wasn't directly working only with oral health, that it was extremely still applicable, that I could kind of weave that into the work I'm doing, both with hospitals, but also all healthcare facilities and providers throughout our state as well. So started to see a lot more of those opportunities where this work is really related to oral health and vice versa. So with that little bit of history on myself, I was asked to kind of provide an overview of what AHECs are, and then what dental pipelines might look like, and kind of the resources AHECs can provide to you and the work that you're doing as well. So I put this title slide on there just kind of as a joke that we always get a lot of questions of what the heck is an AHEC, and we do so much work that sometimes it's a little bit hard to describe, but super valuable resource. So the Area Health Education Center program was developed by Congress in 1971. So it's been around for over 50 years. The purpose of AHECs is to recruit, train, and retain a health professions workforce committed to underserved population. The purpose of the AHEC program is to meet the needs of the communities they serve through robust community academic partnerships with a focus on exposure, education, and training of the current and future healthcare workforce. So when I was thinking about how I explained the overall national AHEC program, like I said, there's a lot of ins and outs of what AHECs do because they vary so much throughout the United States. So I actually found a great video from the National AHEC organization that provides a great history and kind of background of the purpose of AHECs and the services we provide. So I'm going to show about 8 minutes of this video to provide some of that background. And then after that's done, I'll share a little bit of information about the Montana AHEC program and the current activities we have to focus on workforce development, including dental professionals as well. So kind of give you the national overview and then a specific example of Montana, and then kind of share with you how you can reach out to your local AHEC and how that might be a little bit different as well. So with that, the big test, if I can get this video to work. All right.
The AHEC network is all about health workforce development. We literally impact every angle of the spectrum to provide the best quality of care possible.
It was a program that was going to be brought to our community to help improve the number of providers in the community.
Enriching the future pool of healthcare practitioners who then can meet those needs of that diverse population.
Working with young people and working in healthcare. And AHEC provided the opportunity to bring those two together in an amazing and wonderful kind of way.
I just thought to myself, these are my people and I'm at the right place.
The passion for the work that we do, why it's important and how it's impacting and making a difference in individuals and communities' lives.
We've been focused on training and strengthening and developing that workforce for 50 years. And hopefully we'll be doing it for 50 more years.
The founding of AHEC was part of a movement probably from the mid-1960s to the early 1970s.
There was an explosive population growth in the country following World War II, the baby boom. And there was great concern around the country that there would not be enough health professionals to care for the population.
The healthcare outcomes in the United States were not as good as they could be. And there was a lot of access issues, trying to figure out how to do a better job of delivering healthcare to individuals who needed that healthcare. But one of the questions that became central to a lot of the developments that are we training the right people with the right skills to do the job that needs to be done.
And people in Congress and other health planners that were concerned about rural communities and other shortage areas recognized that if there was going to be a shortage of health professionals, a supply for the whole country, it would really be exacerbated and really problematic in underserved communities. Something had to be done.
So the Carnegie Commission looked at that and said, well, here's an idea. And that idea, they turned the Area Health Education Center.
Very soon after the Carnegie Commission report, the support for the AHEC concept spread widely. In 1971, President Richard Nixon, in his health address to the Congress, supported the development of AHECs around the country. In 1972, the very first AHEC programs were funded.
Nobody knew what an AHEC was. At that point in time, it was a very vague notion in a certain sense. The Carnegie Commission saw it as a mechanism to provide patient care, to provide education and continuing education in communities.
The primary mission of AHEC was to build partnerships between academic institutions and underserved communities to leverage the resources of the academic health centers with the providers in underserved communities to increase the supply, distribution, and quality of the workforce. In 1972, what was then the U.S. Department of Health, Education, and Welfare started the first 11 programs, and we fondly refer to them as the first generation.
A number of those 11 programs over the period of time that they were funded, some dropped out. Some decided, well, we really can't do this, or this wasn't really what we thought we signed up for. But a number of the programs did, and we still have some of those programs in existence as AHECs today. So when they funded this generation of programs, it funded 12 programs between 1978 and 1988. There were more requirements. It just became a more structured program.
In 1985 till about 1995, the third generation of AHECs started. From 1995 until today, it's what's been called the fourth and fifth generation AHECs. The original programs were strictly focused on underserved rural communities. And in the later generations, they expanded to include urban inner city communities as well.
So the AHEC network is all about health workforce development. We literally impact every angle of the spectrum, from working with kids and getting them interested in healthcare to helping support current healthcare professionals and make sure their skills are up to par. The thing about the AHECs that really makes that a unique partner that you want at the table is not only do we have access to the future and the current healthcare workforce, but we also have access to communities.
The strength, in a sense, of the AHEC programs is in the regional and community-based networks. They're the ones who are closer to the people. They're closer to the needs in many respects. They're also closer to the political structure. And if we're going to maintain an academic community partnership, we need federal, state, and local participation.
We reached 644,000 participants last year. We really are a big part of this nation's healthcare system. And the chances are that if you've seen a healthcare provider in the last year or two, that provider or clinician has been touched by AHEC in some way.
The scope of AHEC has changed tremendously in the last year due to COVID. But I think what we have found as AHECs are very nimble. I mean, when we're asked to pivot, we pivot, and we pivot well.
I think it highlighted and showcased the capability of AHEC centers and AHEC program offices.
We stepped up and proactively looked for ways that we could chip in and help out.
Out there in the public, they think they know what an AHEC is, but I think because of this pandemic, they know what an AHEC is and how we can contribute.
We are here. We've been addressing these issues of healthcare professional shortages for 50 years. We have the pieces in place. We've been a part of that infrastructure, helping those underserved communities for so long.
The other interesting thing about the AHECs now, as we look forward, is the states are looking to maintain the workforce that was built because of COVID. We don't want to find ourselves in the future in a place where another pandemic comes or there's a huge emergency disaster because of a natural disaster that occurs, and we don't have the public health workforce that we have now. I think that the pandemic has shed light on the lack of infrastructure we have in public health and the strength of the AHECs in building that infrastructure.
All right, and we'll pause there. I just thought that video did a really nice job of sharing a little bit of the history of the AHECs and also the overarching purpose of AHECs as well. So as I mentioned, now I can dive a little bit deeper into the Montana AHEC program and kind of what we have going on in our state. But a lot of these programs are in other states as well, with a different flavor that is more, the cool thing about AHECs is each program and each center really tailors to what that community looks like. So what we do in Montana and what works well for us might have just a different flavor in another state, but they're all gonna kind of support that core AHEC mission of recruiting, training, and retaining a health professional workforce with that rural and underserved priority area. So with that, so this is the AHEC map for the state of Montana. Our program office is located at MSU, Montana State University in Bozeman, Montana. It is part of the HRSA AHEC funding that it is hosted by a medical school. Fun fact, we in Montana just received our received. We just developed our first 2 medical schools that opened in the last year. So when our AHEC program was originally founded, there was no medical school to house it. So it's housed by the College of Nursing at MSU. In this map, I oversee the Green region, so the South Central region. I'm a regional director, and we all collaborate through the state on different initiatives. So I always describe the work we do in 3 different buckets, which really falls in line with the overall AHEC mission. So bucket number 1 is really our pipeline or our pathway programs. This is where we get students interested in healthcare careers, including dentistry. So some programs that we have that are pretty consistent, we put on a Med Start program, which is a summer camp where students come to a college campus. They spend 5 days there. They get to stay in the dorms. They eat at the cafeteria. And then we bring in a whole variety of health professionals to do activities with them that highlight different careers in health professions. Of course, with my background, I'm always super interested and do the strong plug for anything dental related. That's always something so fun I get to do in my role as well, is kind of share the different occupations in dentistry. And then they also do job shadowing, which last year for the Med Start program we put on, we took them to a community health center and they got to job shadow in the dental clinic, which was really eye-opening for some students. I had one gal who was super astonished and loved seeing the inside of someone's knee when she was in the OR of the hospital, but having a tooth extraction absolutely disgusted her. So I'm like, well, this is a learning opportunity. Dentistry is not for you. But kind of gave them those good experiences to see what it might entail. We also do a REACH program, which is partnerships between a local high school and a local healthcare facility where they take those students for the day and kind of put them through the different departments of the facility and do some hands-on activities. We do a heads up camp, which is similar to our Med Start camp that's hosted at a local college campus, but it's behavioral health related. And then we do a lot of work on college fairs and resources. We have a nice crosswalk that we have that provides all the colleges and universities in the state, and then what healthcare programs they offer. Another fun fact, in Montana, we don't have a dental school. So we have a lot of partnerships with like the University of Washington School of Dentistry and work that they do to try to establish programs that take students from Montana, but also get them to come back to us, ideally in the end as well. Second kind of bucket of work is our post-secondary programs. So supporting those students while they're in their healthcare education. We do a lot of work with simulation education training with funding that comes in our state. We do some networking events. So taking students and really pairing them with healthcare providers, creating space where they can talk to potential employers. And that includes dentistry as well. We try our best to include all different kinds of occupations in those events. And then I personally support the University of Washington when they bring students into our state, making sure they have housing accommodations while they're here, which if you know anything about Montana, housing in Montana is a unique problem right now. So just making sure they have somewhere to stay while they're here is kind of how I help them out. I will share a national program that's put on through AHEC is our AHEC Scholars Program. There's more information about it in the rest of that video that I think Francis is sending out after the meeting today. But that is a program where when students are in their post-secondary education, they sign on to this program to do 40 hours of extra didactic and 40 hours of extra clinical education. And it's a lot of topics that is interprofessional education, really preparing these students for practice in rural and underserved settings. So this is a unique and very cool opportunity to introduce these students to oral health and maybe do that interprofessional education with them. I recently presented to our AHEC scholars for the state of Montana, which we have a really outstanding program here. We have it's over 400 students currently enrolled. And so I got to present to a cohort of them about, hey, here's oral health considerations and why you should care about it. So not only supporting those dental students while they're in education, their post-secondary education, but also having that captive audience of educating non-dental providers of why oral health is important as well. All right. Third bucket, supporting our health professions workforce. We do a lot of behavioral health training. We have a CNA program. Probably most applicable is we do a lot of continuing education as well for our existing healthcare workforce. So again, this is education for our dental providers, also for our non-dental providers on topics like oral health. So it can be a very unique way to work with your AHEC to plug that education and that awareness of the importance of oral health. And then lastly, in the last couple of years, we've started being really involved in health equity programs. As part of COVID-19 CDC Health Equity Grant funding, we, within the AHEC Center in Montana, developed an index for healthy communities, which is a unique tool that takes data specific to health outcomes and then data specific to social determinants of health, and created a really cool index that looks at the two of them and helps hospitals identify areas of opportunities for how they can target interventions in their state. And we also developed a regional health equity task force kind of structure that is currently, we're trying to move that into a formal network as part of a HRSA network planning development grant. So again, kind of plugged into the health equity work as well. And with all that information, that's kind of the overview I had, but I would welcome any questions, any chat, any discussion you might have about how you might be able to partner with AHECs in the work that you do.
So we do have a question from Sue. Dr. Keller, do you want to come off of mute and ask your question, or do you want me to share it?
I have never heard of AHEC before, and I'm wondering if they exist in Massachusetts and on the East Coast.
I'd say very likely yes. Most states have an AHEC program. On the National AHEC website, which I can send a link to, they do have a list of all the AHEC programs, but it's a HRSA federally funded program, and most states do have an AHEC program, or some even have multiple programs. They're kind of unique, hidden gems in a lot of ways that for some reason, like, what the heck is an AHEC? Just because we do so much that sometimes it's hard to describe. But once you kind of partner with an AHEC and learn about the resources and partnerships that are available, it can be really beneficial. So Sue, if you need help finding or connecting with that, just let me know.
Thank you.
I have a quick question, Katie, and that is, if the AHEC in your state doesn't do anything about oral health training or education or any of that, is there a best way to contact them to see about partnering with them to include oral health?
Definitely. I would say just reach out, see what they're doing, and kind of share like your background and what you're interested in promoting, and have a chat with them. We're always looking for new ways to be innovative and to address the factors that are influencing the health of our communities. So the typical AHEC structure, normally there's a program office, which is the office that kind of oversees the whole statewide program. And then there's regional directors. So that's my current role as a regional director. So depending on kind of the scope of what you're hoping to look into, you can either look up a regional director for your area, or you can look at that program office, which is going to be more of a statewide approach. But I would go out on a limb and say most AHECs are very friendly and open people. Just give them a call or an email and share what you're about and see if there's any crossover or collaboration opportunities.
So also, Nancy wanted to know, our AHEC focuses primarily on physicians, and how can you redirect them to oral health as well? I kind of think you touched on that just now with your last response. So didn't want to overlook that, but that was in the chat as well. So it seems like you have provided me with some background information. I wasn't quite sure how I got involved in oral health, but I kind of think with Health Power Associates, I did have some clinical experience as a dental hygienist in my second year of the hygiene program, working in a low income clinic. At the time, it was in the inner city, and that was my first employer after after finishing school. So I appreciate that, and I continue to want to know more about AHECs. So thank you so much, Katie. Any other questions from the group? Or
I have
anyone wants to
less.
share out? Go
I have,
go right ahead.
okay, thanks.
Go ahead, Deb.
So my question, Katie, and then I'm going to put a link in the chat, or I'm going to hit send on a link in the chat that says I have to hang my head in shame that Minnesota is one of the states that doesn't currently have an AHEC. And I know that they used to. So my question is twofold. Is there a way to find out the history of why that went away? Who would a good contact be for that? And are there any AHECs that maybe say are just about the dental professions? So we've had questions about it being about physicians and not having that. But if we feel that, if we, meaning the dental stakeholders, feel that that might be a way to get one back, how would we go about organizing an effort like that?
So Deb, this is Clarence Jones. Can you hear me?
I can.
Okay. I was actually a member of the AHEC when they were here in Minnesota, and I was with the medical school. So I was also with them when they dissolved. And so I cannot tell you all the background of that, although I know that it was it could have been a very, very positive work. So that's all I'm going to say. But I would love to see AHEC again here in Minnesota, because I saw the potential for the work that could have occurred.
Cool. Well, Clarence, we've got something to do together in 24.
And Deb, also to touch on kind of the dental aspect you talked about, based on the funding structure from HRSA and kind of the intent of these programs, I don't know that you'd ever see one that's just dental specific, but you can absolutely, dental is a part of overall health and part of these teams, and definitely working with those AHEC centers to make sure that's something that's really pushed and that there are activities, and there can be activities absolutely that are dental specific. Probably not the overall mission of that AHEC, but they can definitely have programming specific to dentistry.
Thank you so much, Katie. And I'd like to ask folks to either come off of mute, and you've already done that. So thank you so much for your participation. And if you have any resources you would like to share in the chat, please do that as well. I see that we have a link from about AHECs in the chat as well as the video. So keep them coming, guys. So our next presenter will please help me welcome Matthew Schaefer. He's Deputy Policy Director of the National Center for Interstate Compacts from the Council of State Governments, and he's joining us from Lexington, Kentucky. So he'll be sharing with us about the Dentist and Dental Hygiene Compact and what are some of the health professions with compacts, as well as backgrounds in those states that allowed this work to happen. So let's welcome Mr. Schaefer. Matthew.
Great, thank you. Good afternoon, everybody, and pleasure to be here talking about the Dentist and Dental Hygienist Licensure Compact. Let me just share my screen here briefly. Everybody seeing that okay? Great. All right, so like Celeste said, I'm with the Council of State Governments. I'm in CSG's National Center for Interstate Compacts. So CSG has been involved in facilitating the development process for all of the active licensure compacts that exist, including this one for dentistry, but there's 15 others, primarily in healthcare. And I'll show you the list on a later slide, but we're kind of the neutral facilitator of the process to develop the compact and then provide education during the legislative enactment portion of the process. Okay, so what exactly are we talking about when we use this term interstate compact? What we mean is a legal, legislatively enacted contract between two or more states. So just as two businesses can enter into a contractual relationship with one another, states can actually do the same thing and formalize these agreements, and these are called compacts. And they're legislatively enacted. That's a common question that we get. How does my state sign up to join the compact? That is an act of your state legislature. So they pass model legislation, essentially saying we are agreeing to join this compact with all these other states. And you can see there on your screen the picture of the driver's license, which is probably the most common example of a compact. So rather than the federal government coming in and saying, states, you have to recognize each other's driver's licenses, the states came together and developed the driver's license compact, which allows you as a motor vehicleist to drive across state lines without having to get a new license when you cross the state border. So a lot of these licensure compacts really work in a pretty similar manner to the driver's license compact. So here's the list of professions that currently have these in place, along with the organization that we partnered with to develop the compact. So you can see there, dentists and dental hygienists. We worked with the American Dental Association, along with the American Dental Hygiene Association as well. But you can see primarily healthcare, allied health professions are the ones who have been the early adopter of these compacts. We have been moving into non-health spaces with professions like cosmetology and teaching. Okay, so primarily what these compacts are trying to achieve is the facilitation of multi-state practice. So how do I, as a licensee, have the ability to practice in multiple states simultaneously without navigating each state's specific licensure process? So I'm sure we're all familiar with the barriers that licensure poses. Sometimes you're waiting weeks or months on a licensing board to issue you a license when you move to a new state or you want to practice across state lines. And that can be extremely burdensome and often comes with additional paperwork and even examinations or testing to be able to get your license in a new state. So the compact is trying to streamline all of that and facilitate the process for you to be able to practice in other states in a streamlined manner without needing to obtain individual licenses to work in all the individual states. So think about the analogy that we just gave for the driver's license. Really same principle applies here. You maintain one state issued license and you're able to practice in the other member states that are a part of the compact. You can see here just how popular these have been in recent years. Just in the past 7 years, almost 300 pieces of compact legislation. I showed you the list of the 15 professions that currently have these, and almost all states have adopted at least one of these compacts. The only states that have not up to this point are California, New York, Massachusetts, and Alaska are the only 4. Another thing that's important to emphasize here is preservation of state authority over professional licensing. So this is not like a takeover of the licensing system that exists in your state. This is just creating a additional optional alternative pathway to practice if you want to be mobile or work in multiple states at one time. So the compact does not speak to scope of practice. It doesn't speak to state-specific licensing requirements. So all those things remain in the purview of the state, and the compact doesn't dictate any of that. So the state continues to define their requirements for their license, and they continue to define scope of practice. So the compact would never say, define a specific scope for hygiene or a specific scope for dentistry. That remains in the purview of the state. And when you're practicing in a state, whether you hold a license or you hold a compact privilege, you have to abide by that state's scope of practice wherever you're practicing. Okay, so just to briefly summarize some of the eligibility requirements. So this isn't open just for anybody. There's a standard that's set in the compact that all the licensees have to achieve in order to be eligible to use the compact. And these are reflective of the common licensure requirements that we see across states for dentistry and dental hygiene licensure. So holding a qualifying license, our definition there for qualifying license is that it's active and unencumbered. So if you have any kind of current actions from a dental board on your license, you would not be eligible. So your license has to be totally clean. Pass your national board exams, CODA accredited education. We do define for the dentist that it is a pre-doctoral dental education program. So a CODA accredited residency would not satisfy this requirement. It would need to be pre-doctoral dental education leading to DDS or DMD. And then successful completion of a clinical assessment. The compact is agnostic as to which clinical assessment you completed, as long as you completed a clinical assessment. So there's the hands-based regional examinations out there like ADEX or credits or CERTA. There's also PGY1, which a lot of states utilize, or the Delaski. So all of those would satisfy this as you proving your competence in form of a clinical assessment. And then lastly, completion of a criminal background check. Okay, so let's talk about some benefits. So obviously the primary benefit here for the practitioner is the facilitation of multi-state practice. You're no longer bound to only practicing in the state where you have a license. You're able to practice in all the other compact member states in a streamlined manner. Also enhances portability when you change your residence or move to a new state. So if you're a highly mobile population, like we often hear about military spouses who move every 1 to 2 years, the compact would benefit you so that you don't have to get a new license every time you move, but you could just utilize the compact to practice in your new state. Obviously expands employment opportunities. You're able to expand your market share and go and work in other states where maybe previously you did not have access to. I mentioned the point around relocating military spouses. I haven't mentioned this up to this point, but DoD, the Department of Defense, actually funded the creation of this compact because they are so motivated to solve this problem for their military spouse population. So they paid for the creation of this compact in order to help their military spouses who are in dentistry and dental hygiene. And then obviously reduction of burden, financial burden, maintaining multiple licenses. So you're no longer having to pay for multiple renewal fees and multiple, continuing education requirements and things like that, that are all associated with maintaining multiple licenses simultaneously. Okay, so benefits to the dental boards, reduction in administrative burden. You're no longer having to process as many out-of-state applications, and so there's a reduction in the staff burden to have to administer the application process for all those out-of-state licensees. Just generally helps state boards work better together around things like discipline across state lines and investigations for practitioners working in multiple states. And then lastly, enhances public safety through a shared data system. So the backbone of all of these licensure compacts is what we call a shared data system or information system that basically houses licensure data about licensees using the compact, and all the member states have access to that. So you'd be able to see things like the availability of current investigative information, any significant board actions that are taken, and all the member states would know about that and have access to that information. So there's really no scenario where a bad actor could like hop from state to state undetected because of this data system, this notification system that's in place. Somebody is under investigation in another state, all of the member states would know about that with this shared data system. Okay, and then lastly, benefits for states. We often hear about compacts in discussions around workforce and workforce shortages. We hear all the time about workforce shortages in oral health care, particularly with dental hygiene and dentists really struggling to be able to hire hygienists and staff their office properly. So we see the compact as a workforce development tool. It's certainly not a silver bullet that will solve all of the state's shortage areas, but it is a policy option that could make it easier for states to be able to recruit and hire and make it easier for dentists as well. And then I made the point about preserving state sovereignty. So we're creating this new pathway to practice that allows people to be mobile while simultaneously allowing the state to continue to govern for themselves the practice within their state borders. So things like discipline and licensure requirements and scope of practice, all those things are retained by the state. So legislators really aren't seceding any of their authority by joining the compact. Okay, so next steps, the model legislation has been finalized and is out to the states for enactment. I'll show you a map of where we are at with current legislation. We are working with the ADA and ADHA on giving education to interested stakeholders who are interested in potentially pursuing the compact. I'd also encourage you to check out our website, ddhcompact.org. There's a lot of good informational, educational materials on there for you. And the compact will be active when 7 states enact it. Currently, we have 3 member states. So none of this is in effect currently. This is all something that will come into effect upon enactment by the 7th state. So you can see here the number of, we've got our 3 member states, Washington, Iowa, and Tennessee. And you can see there where we have pending legislation. So our Minnesota and Kansas bills will carry over to 2024. We could still potentially see movement this year in New Jersey and Ohio and Wisconsin. So those are the states that we're still monitoring. Minnesota and Kansas will be bills for next year, but did go ahead and introduce the bill during 2023. Okay, so I just briefly, before I close, want to touch on some of the stakeholders who are involved here in advocating for the compact. So I've mentioned CSG, I've mentioned the ADA, I've mentioned ADHA. Probably the most important entities here in terms of actually advocating and lobbying for the legislation are going to be your state associations. So that'd be your state dental association and your state dental hygiene association. They're the ones with the network in state to actually get this thing off the ground and get it passed. They're the ones that have ability to hire lobbyists and things like that. So they're a very important entity. So if you're wondering how to get involved, I think that's probably the first touch point you need to make is reach out to your state dental association or state dental hygiene association and see where they stand on the compact. There's a couple other groups here, the Association of Dental Support Organizations, or ADSO. The DSOs are really supportive of the compact, and we've seen them take the lead on getting bills introduced in several states at this point. The ADA does facilitate a group called the Coalition for Modernization of Dental Licensure, and one of their core objectives is to advance the compact. So I'd encourage everybody to check out the coalition if you haven't already done so. And then the last group here is the dental schools. They're probably lowest on the list in terms of who actually is involved in pushing this, but we do feel like there are benefits to the dental schools in streamlining the licensure process and helping dental and dental hygiene students navigate the licensure process post graduation. We feel like the compact would make lives easier on that front. Okay, so here's our website again, and just a couple examples of some of the educational materials. You can find the final compact language there, as well as a one-pager, which really kind of explains all the information that I gave you today, and the map that we keep updated with all current pending legislation. So with that, I'll be happy to answer some questions, and you can see there my contact information on the screen. We've got a general email inbox, dentalcompact@csg.org, but my personal email is there on the screen as well. So I know we've got a few minutes until the top of the hour, so I'm happy to take some questions.
So thank you so much, Matt. And I'd ask folks to come off of mute, and any questions or insights, please share now. Any relevant resources in the chat. And as Matt said, if you have a question, now is the time. I know
Hi, Matt. It's Jim
we
Schultz.
have
How
a
are
few
you?
in the chat.
Hey, Jim, good to see you.
Got you.
You as
Great.
well. Matt, and I know you're here really on the policy side. I didn't know if you wanted to talk about some of the politics on this, so folks on this really can understand and help unwind some of the political implications that have been going on, just to see where some blind spots might be and how they could help fulfill that that political piece of that. I know you're always a little hesitant to do that since you're trying to keep it in the cleaner spot, but I think it's important that we know our political adversaries as well in this space.
Sure. So, yeah, Jim's absolutely right. This has been certainly keeps my life interesting, but it's the most probably contentious compact because of some of the opposition that we're getting, specifically from the dental board, so the regulators. And if you're not familiar, the American Association of Dental Boards, or AADB, has actually proposed their own alternative compact language, which seeks to rectify some of the shortcomings that they perceive in this particular compact that we are proposing here. And I'll just say on that front, we invited AADB to participate at every step along the way in the development process, and they chose not to do so. So a lot of these concerns that they're bringing up at this time after the compact has been finalized were things that were thoroughly discussed and negotiated through the development process. So that's just a stakeholder to be aware of. AADB, if you are involved in advocacy in your state, they will likely also be there as well, pushing back. So they will be working through the dental board, or doing some. I know in Ohio and Pennsylvania, they actually have hired lobbyists to and New Jersey, they have hired lobbyists to try to oppose the compact, and so they are working on the opposite side to try to slow this down. I don't actually believe that the AADB compact is a good faith effort to try to create a alternative that's viable. I think really their goal here is just to slow walk this process and make it as challenging and difficult for us as possible. But yeah, I'd say work with your state dental association, work with your hygiene association, and there's a lot of coalitions that can be built on the other side to combat kind of this very small vocal minority that's trying to make things difficult for us.
Matt, this is Nancy Partika from Hawaii. If our local dental association appears that it would oppose this, is there any point trying to move this forward without them? The hygienists, I don't think are a problem. I think our dental association would be. What would you advise?
Sure. So we have seen some instances where the state dental association is neutral and the hygienists push it forward, or the DSOs push it forward. And I think in those instances, there is the potential for success. I'm not sure you can be successful if the state dental association is actively opposed to it. I'm not aware of any legislative body who would take that kind of an action that's in direct contradiction to one of their state associations. So I would say do your best to try to get the state dental association to neutral, and then let one of these other groups take the lead.
Okay, thank you.
Matt, I'm from Iowa, and we were the first state to pass it. So it was even brought up by my legislator. So I was excited. But I know one of the questions is, and I know our dental board was not really against it actively, but in behind the scenes they were against it. But one of the questions was that some of the criteria that you said to make them sign the compact, or the minimum criteria as far as that you gave on one of the slides, is that criteria can change at any time. Can you talk about that?
So the requirements on the dentist side to be able to use the compact, those are written in statute, and the only way those could change is if all of the member states agreed to collectively change the compact. So CODA accredited education, your national board exam, a clinical assessment, those are things that are locked into the statute, and so those could not be easily changed. The only thing where there's going to be some flexibility on the commission side, the group that actually governs the compact, will be around the definition for clinical assessment. So they could vote to there's other pathways out there. The one that keeps getting brought up is the Marquette Dental School. The Wisconsin Dental Board just approved them to be a testing agency, and so the commission would vote to say, is this a viable pathway to practice under the compact? My gut is that they would not, because Wisconsin's really the only state out there doing this. So there's some nuance to how that specific requirement is interpreted, and that will be up to the member states to define. But a lot of those other ones, CODA education, your national board exams, having a clean, unencumbered license, those really cannot be changed.
I had an in the weeds question about CMS and the relationship between a compact participating provider. Can they just then apply to be a certified Medicaid provider in the compact states, like in all of them, without going through anything except the certification process? I mean, do they have to do, will that work, essentially?
Yeah, and that's a good question. And from my understanding, and we have guidance that CMS has actually put out to say that they do not distinguish between a regular license and a compact privilege. So that's the thing that you're receiving under the compact is a privilege. So they're from their perspective, there's no distinction between the two. So they would treat a compact privilege essentially as the same as if you held a license for insurance purposes.
Thank you. That's really good to know.
So there's one more question. What would be the preferred state for a dental or dentist, I guess, or a hygienist to get their initial license in, considering that states would have the compact and also with the broader scope of practice?
Sure. So, I mean, we really don't see there's not really any outliers out there in terms of one state who is drastically lower standards that, would be really easy for you to get a license. We don't really see that. I think we're as close to parity across the country as dentistry has ever been in terms of, everybody requires CODA education. Everybody requires some sort of clinical assessment in passage of the national board. So, in terms of, perceptions around, oh, maybe there's one state out there that everybody's going to flock to because it's easier to get a license. We just don't really see that. I think most states are kind of on par with each other in terms of what the requirements are.
Matt, that was my question. I actually had the opposite concern. In other words, which state has the hardest license to get? Because my understanding is that if you hold a license from a state and you also hold the compact, you can only practice within your scope of care in your own state. In your own state, even if you're in another state, you can never exceed what your scope of care is within your licensure held state. So if Celeste in Louisiana can't apply fluoride varnish without a dentist in the room, and she comes to Massachusetts and on a compact, she still can't apply fluoride varnish without a dentist in the room, even though in Massachusetts that's actually allowed. So it would seem that you would want to try to get your license from a state that has a higher scope of care, because then you're never going to get trapped into a lower scope of care. Does that make sense?
Matt,
Jim, do you want to say something?
Yeah, so this is a major contention among the boards and a lot of unwinding on care on this. You are regardless of what your level of education or your scope may be in your home state where your license is, you are limited only to the scope that is available within the state that you are practicing. So, for instance, local anesthesia for hygienists, that's a good one. Not every state allows local anesthesia for hygienists. So even if you can perform local anesthesia in your state, if you're practicing in a state that doesn't allow a hygienist to practice, to administer local anesthesia, you may not do that. So even though you might have the skills, it doesn't mean that you can do that. So the big contention, and I'll tell you, there are three principal opposition points that state boards have elevated. One is the lack of clear physical, psychomotor calibration for examination for licensure. The other is the numbers of continuing education credit hours, and very specifically, many of the states now are demanding additional localized hours for licensure. For example, opioid training. We know we have the MAID Act for the dentists who are prescribing. There are other states who have attached additional CEU credit hours on that. There are things about cultural diversity requirements that some states have that other states don't have. And so the notion of this is an area where the dental boards are raising what I believe valid, confusing argument points and saying, hey, look, if somebody from Pennsylvania comes to New Jersey, they don't have the CEU hours that our dentists in New Jersey have, because they're mandated with these credit hours to take certain competencies that aren't required in their home state. So I do think that's something that the compact will have to unwind and recalibrate as a larger group as this thing becomes law and becomes effective. So I put that out because those are very difficult challenge questions that we are having. And the outright opposition, the politics here is it's the opposition of subtlety and inertia that we really have. It's sounds kind of a neat thing, but I don't know if I want to be the first one to do this, and I really want to see how this unwinds. I have a lot more questions than I have answers for. Maybe we should just go slow and not be the first state. And that right now is, I think, one of the barriers out there. I think a year from now, we're going to have a very different conversation in this group about this issue.
Yeah, thanks, Jim. And Jim's been our go-to guy in New Jersey, and hopefully they'll be our fourth state by the end of the year. So
working on it.
Okay, guys, I appreciate the conversation, but we need to stay on target. We have a few more presenters. So we do want to move forward. I want to thank you, everyone, for this conversation. This has been fantastic. But now we would like to welcome John O'Malley, biostatistician from CareQuest Institute for Oral Health. He's joining us today from Chicago, Illinois. So welcome, John.
Hello, everyone. Just double check. Will you advance the slides for me, or do I share my screen?
Up to you, whichever you'd prefer.
How about you put it up? Because with my multiple screen system, it always gets messed up. Thank you very much. And so I'm John O'Malley, everyone. See some friendly faces on the call. I'm not in Chicago today, though. I am in Ann Arbor, Michigan. Although Chicago is a good guess sometimes. I do like to go back home. I have many oral health friends from my Illinois community. So today I was asked to talk a little bit about dentist participation in Medicaid, and I'll confess that has not been a huge priority like research at CareQuest lately, although We are gearing up to acquire a data set that would let us do that next year, and we're really excited for that analysis to come out sometime from now. But instead, so I think what we'll do today is cover a bit of what our friends at the ADA's Health Policy Institute have been putting out, because I think they're the ones who have been on top of this more than anyone, and they have some really great infographics here. And so I'm just going to take a few minutes, not much time at all, just to go over, like, when we talk about dentist participation in Medicaid, like, what are we really even talking about? What are we measuring and what are we seeing out there? So I'm splashing up on the screen this great infographic from our HPI friends who are in Chicago, of what they put together based on the HRSA CMS Insure Kids Now database. Some folks might be familiar with that. It's designed as a consumer-facing tool. We can go online and kind of find out where your dentist might be if you're looking for a dentist for your child. But as a data set, it shows where dentists are participating in Medicaid. Just, are they enrolled? Can they participate? Whether or not they are. And so based on HPI's output, we have 43% of dentists nationally are participating in Medicaid, which I think sounds like a pretty big number for us in dental public health. And we'll go deeper into like what 43% really means in a moment. Not quite yet, but I think this infographic is great at showing some of like the disparity in the distribution across different dentist characteristics and different geographies. So yes, 43% overall. Female dentists are more likely to participate in Medicaid than male dentists. White dentists are the least likely to participate in Medicaid of all the race ethnicity categories. Pediatric dentists are the most likely to participate in Medicaid. And then of the other specialties, it goes down like pretty sharply. I don't think that's a surprise to many folks either. But on that chart on the left, which is very hard to read, I'm sure, and everyone's screens, but it's not hard to find this infographic at all. It's out there. If you wanted to see what the rate is within your state, it is ranked there. And you can see it goes like, you're in from the teens to the 70s percent of dentists in different states participating in Medicaid, which is like quite a range to see. We don't see that much difference in many things in oral health, but that's a lot. And I know most people, when they talk about how do we get that rate up, the first thing is you go to your fees more than anything. And there's research to show that that is true, although that's not the only thing that you can do. But if we can go to the next slide and dig deeper into like what it really means, what that 43% really means. This again is going to be kind of hard to see. You're going to have to like max out your screen, and it's not hard to find this on ADA HPI's website. But they took a different data set that actually had claims involved. The TMSIS data set from CMS, if folks are familiar with that. And they looked at like what Medicaid claims dentists were actually submitting to see like how deep is this participation, not just are they in it or not. And then they ranked states based on what percent of dentists within a state not only are participating in Medicaid, but are seeing 100 or more Medicaid patients in a year. So it's kind of like a complicated graphic, but if you look at just like that deep red color on the right side of each state, you're seeing the percent of dentists that are seeing 100% or 100 patients or more. So Vermont is 34% of all of its dentists, like in the entire state of Vermont, 34% of them are seeing 100 or more Medicaid patients, which I think is like, that is some depth. That is, they're seeing a lot. So that's like, the patients are being distributed pretty more equitably across dentists than maybe other states. Yeah, some of them are scraping the bottom, but that's okay. We could talk about ways to kind of fix this. Oh, maybe you can tell me, Anne, what very deceptive numbers means there, but this is, it's kind of like one of the most, I think, like detailed ways you're going to be able to get at this by looking at like actual counts that there's, counts of which like they're being seen. You have states at the bottom there where just like not many dentists are seeing that many patients at all. So I don't know, I guess I could stop there and maybe invite like our next speakers to kind of pick it up from here about or where you go from this. Yeah, so I just speak to Anne's comment about people who apply for Medicaid and only see one person. Just for this chart, if you were to look at like the second lightest color on the like the second color from the left within each state, it's kind of like not the lightest pink, but the second lightest pink. That is people who are enrolled in Medicaid but not seeing anyone at all. And so you can kind of track how in some states that's a big bucket of dentists who are just in the program and not doing anything. But in some states there are, like, that's actually pretty small, that if the dentists are in, they're at least doing some care. So just showing some interesting, I think, geographic variability there. But I'll pass it on to my colleagues next, I think.
Thank you, John, for the overview, and we will ask for questions and key takeaways. But because of time, I'm going to ask that we hear from our open representatives to share the same some innovative strategies in support of Medicaid expansion and provider enrollment. So keep the ideas and the conversation going and resources share in the chat. We'll hear from Missouri Oral Health Coalition. Gary Harbison is here to present today. Thank you, Gary.
Can you see my slide?
Yep.
Can you hear me?
Yes and yes.
Yes, yes.
Okay, so I just created a quick slide about what we have going on. Whoops, let me back up there. So, you know, we did get a significant rate increase that went into effect last summer, July 1. We went up to 80% UCR, so basically commercial levels for Medicaid. And, you know, don't think that makes everything wonderful. I mean, it's great. It's a great accomplishment. What it's done is given us a wonderful set of problems to have, not the least of which is getting providers to sign up. And by the way, yeah, I generally, my rule of thumb about the HPI data that you showed for Missouri is, yeah, around 36% are signed up for Medicaid, but only half of those are seeing anybody in Medicaid at all. So pretty low actual real participation. So we were able to get some grants from Missouri Foundation for Health and Health Forward Foundation to support work to enroll more providers, because we felt the depth of issues with providers enrolling for Medicaid is noteworthy. And I think in many instances, you're asking private practices that have never worked in Medicaid to kind of break through that brick wall, real or imagined, and start seeing Medicaid recipients and working with the differences on the business side that Medicaid presents. So we got those grants. We started work right away. We've had a very good, close collaboration with the state Medicaid agency, which has been wonderful. It's called MoHealthNet in Missouri, or Missouri Medicaid. And there's another component that does the actual enrollment of the state called MMAC, and they also do audits. We're working very closely with them. That's been very important. And of course, with the Missouri Dental Association, we were able to fund a targeted media campaign related to this. So a professional targeted media campaign. The link's in there on our website, oralhealthmissouri.org. You can find the Mo Medicaid Matters link on there, and you can go in and see some of the resources we have out there, including the recordings of webinars and that sort of thing. It also funded a full-time staff with the coalition dental Medicaid facilitator, whose job is to work directly with providers and get them enrolled, make sure they have whatever they need to have to get enrolled. I would say throughout this entire process, we've constantly been identifying other barriers, and we've tried to respond to that. So, for example, providers that are interested and are talking to us have said things like, I would sign up, but sedation's a big problem for anybody that I would see that would need sedation. It's very hard to access. So we did a webinar about sedation to try to get more information out about how that can work, and about a particular provider that is is doing sedation for Medicaid recipients. There's a lot of sort of detail to that I'm obviously not going to go into here. Just specialty providers in general is a big barrier. And then there's also other things that are more kind of functional problems. Probably the thing we still hear about the most is the credentialing time. Missouri has both fee-for-service and Medicaid managed care. Credentialing for the plans is lengthy, circuitous, difficult, and problematic. This is from the perspective of many of the providers we talk with. We are trying to work on that. We did work with that MMAC component, and they very quickly reduced their turnaround time when you enroll in Medicaid. It used to be weeks before they would hear from the state Medicaid agency. Now sometimes it's just days from when all the material's in. So that has been a tremendous improvement. Credentialing continues to be a big problem. We have had discussions about trying to make that essentially one process. So if you enroll for Medicaid to be a dental provider, you are automatically enrolled for the credentialing process for each of the 3 plans that are operating in the state of Missouri. We don't know where we'll get with that. That's kind of a heavier lift, but the great thing is we're having discussions about that sort of thing, and we weren't before. We've done a lot of education, webinars, blogs, fact sheet, resource lists, those kinds of things. We're exhibiting at fairs. We're getting the information out through the media campaign to the landing page that get people to go to the landing page and then sign up for things. We've also, very acutely identified some of the weaknesses in the coverage, particularly for adults. It's not comprehensive here, and are in the process of honing in on some particular asks that we could try to change the policy that would make it more appealing for people, for providers. We actually have got an updated number. We got 184 new dental providers enrolled through the state fiscal year that ended July 30th of this year. We're getting other pieces of data. The state actually got hacked. Their system got hacked. And so we're just now starting to see some provisional data that we were supposed to get back in October. And that's why now we're saying 184 new dental providers. That's providers that have not been enrolled in Medicaid before. Of course, we want total number of providers. We want the service delivery level. We want to know how many participants are getting dental care now, especially compared to the past. Long story short, lots of work. It's going to take time. 80% UCR is wonderful. It's not going to just flip a switch and then everybody signs up and we're all happy. It's more difficult than that. It takes more time than that. Of course, the pandemic had a particular impact. I know that's kind of most of my presentation. If you wanted to see some of the targeted ads on the next slide, I think they might run on here. Should I skip that, or I don't know how you're feeling about time?
I think. Go ahead, Francis. I was just going to say possibly we can drop them in the chat or send it as a follow-up because we still have one more presenter and then we want to have time to close out. But excellent sources. We appreciate your sharing. More is always good, so we know who to touch base with. So definitely thank you for that information. So we're going to move right on to Pennsylvania Coalition for Oral Health to hear what they're doing in terms of Medicaid enrollment and expansion and provider enrollment. So Nicole Payonk, it's your time.
Close enough. Thank you, Celeste. My name is Nicole Payonk. I am the Policy and Advocacy Coordinator for the Pennsylvania Coalition for Oral Health. And I do have to say that A lot of what we're doing here in the state has been things that have already been covered today. So I loved Montana's presentation on the AHECs. We partner quite frequently with our PA AHECs, doing a lot of the same type of data tracking as well as interventions that Gary just spoke about in Missouri. So I can kind of give you what that looks like specifically with Pennsylvania. So just as a bit of background, Pennsylvania previously had a comprehensive adult dental Medicaid benefit. Unfortunately, as part of a budget cut, those benefits were changed in 2011. And I say change because, you know, the realm of politics gets really hung up on words. I want to say they were cut, but in all fairness, they were changed. And what happened was our Department of Human Services issued a bulletin saying that what was previously covered, specifically like roots, crowns, your caps, would still be covered, but you would have to go through the BLE process. And the benefit limited exception process is really just an administrative burden. It creates a barrier for patients and providers to get the care that they need. And it also creates a higher threshold of medical necessity. And at one point in the state, less than 1% of our BLEs were getting approved. So pair that on top of low reimbursement rates and providers struggling with working their way through the credentialing process and enrollment process. And, you know, we really have a perfect storm of dissatisfaction as well as an increased burden of disease. So PCOH has really developed a multifaceted approach on how we're going to work to get these benefits back. And I will say with our legislative process this year, we have been the most successful. So we have tried going through by advocating to our governor directly, who is a new governor. He did intend to put an 8% increase. However, that fiscal bill is still sitting in a General Assembly and hasn't moved anywhere. We have a great relationship with our administration, specifically the Department of Human Services, the Office of Medical Assistance Programs, and our Chief Dental Director. And so they have been working to incrementally make some changes. And we're, of course, trying to get them to just reissue a bulletin to restore the benefit as it was in 2011. But they're telling us it's based on funding. So that brings us to our third arm, where we have a House bill and a companion bill in the Senate that would require our Department of Human Services to restore the benefit as it was in 2011 to get rid of that BLE process. And I'm sure as I, rushed through that, for anybody who's not familiar with the PA political system or just politics in general, it probably sounds like I was speaking a different language. And I will say, coming into the world of oral health and adapting my knowledge of the political system to that, I felt like I was trying to learn a foreign language, learning about oral health and what a BLE is. So that was really one of the main interventions that we realized we needed to do, which was to bridge the gap between Harrisburg and our provider community or our Medicaid community. And we needed to educate them on both sides so they could speak each other's language. And we've had some really great opportunities. And specifically, there's going to be the prime sponsor of our Senate bill. He's going to go out into his district, and we were able to connect his office with a local FQHC. And they're going to be doing an in the district segment where they talk about the importance of the Medicaid bill and how that really affects what's happening from the provider and community perspective. So very excited for that to happen, especially as we move towards the end of, the session days that we have this year. But to help everyone speak each other's language, we created targeted documents, and these are just snapshots. If anybody wants the actual documents, please feel free to reach out. And it was based on listening to legislators talk and ask questions about oral health and Medicaid. So we really kind of made an impact document. And answered all of the questions that they asked during these committee hearings, during the floor sessions, because we thought we gave them that information, but it's still confusing. And then on the other side of that, we created a document to help our advocates. When we ask for an action alert, we may ask for one just to get the bill out of committee. And then there's confusion when we need to get it off the chamber floor. And so we worked to create kind of a document of how a bill becomes a law and the different opportunities for individuals or organizations to engage in that process as advocates. We also have been working to develop and make localized data accessible, whether that's for legislative use or for our advocate use or anybody who's doing research on the dental workforce or the dental status of Pennsylvania. So up here in the top corner, there is a dashboard that is housed on our website, and it is based on the licensure data that we receive from the state board. So we are tracking how many licensees are in our state. How many licensees are we losing each year? And then we actually had the opportunity for an intern to work with the coalition as part of his public health degree. And based on the Oral Health Workforce Research Center's circle plot, we developed one for oral health data tracking. And it looks really crowded, but there are 67 counties in Pennsylvania. And based on the Healthy People 2030 goals, or you could adapt it to your individual state's oral health plan, we created a circle plot to show the oral health status for each individual county. And that data is really helpful when we're looking at engaging with legislators on a local level, because sometimes they want to hear the what's in it for my district as opposed to the statewide kind of status. So, of course, we would love to believe in the field of dreams mentality that if we restore the benefit that the providers will just come. Unfortunately, we know that that's not something that we can guarantee. We're already losing significant providers, and of the providers we do have, we have a very small margin that are actually signed up with the Medicaid program, let alone billing a meaningful amount. So when we look at our Medicaid data that we get from our Department of Human Services, we always pull out by specialty, very similar to what John showed. And then we look at how many of those providers are billing over $10,000 or more. And for 2020, it was just over 1,000 providers for the entire state of Pennsylvania. Like I said, we have 67 counties. So we know the need is not being met, and we need to encourage and support providers in engaging with the MA program. So using the same multi-focused approach, we of course want to have opportunities for legislative changes. So again, advocating to restore the benefit, supporting scope of practice laws. We have a bill currently that will allow PhD-HPs to complete our mandated dental screenings that happen in our schools. So not only will that allow PhD-HPs to fulfill their scope of practice, but it will also keep a dentist at the clinic in a chair doing those high-level services that need done. And then, license portability. Absolutely, that's something, PA, we have legislation introduced in the House and the Senate, but just as Matt and Jim and everyone spoke about, there's opposition. So putting together a statewide webinar to give our stakeholders the opportunity to learn about all the license portability options, and hopefully recruit some advocate providers along the way to help get this legislation moving. But as we move into 2024, we really want to focus on making sure providers know how they can best maximize their engagement with Medicaid. So what is happening in their clinic setting to, get the most out of it? Is their workflow maximized? Are they using their PhD-HP if they have one to the full scope of practices? Are they out in the community practicing? Are they using EFTAs to their full scope, or even incorporating CHWs, especially as we hope to in 2025 get CHWs able to bill Medicaid. So we're going to be doing a lot more outreach and effort on that, as well as looking for innovative solutions regarding loan repayment, and if that can or should be tied to Medicaid in some ways. Looking at public and private partnership models, and really just trying to do what we can so Medicaid doesn't, so we drop the stigma that is often associated with being a Medicaid provider. We really are working to challenge that on all levels. So can stop sharing my screen. I apologize that that was really quick, but I was hoping to make up some time. Yeah.
Thank you so much, Pennsylvania, for the work you're doing. And I'm going to toss it to Beth to close this out.
All right. Thank you,
So
Celeste.
continue to share in the chat. Thank you.
Yeah, that's fine. Thank you so much, Celeste, and thank you, speakers. As a reminder, today's recording and all the resources brought forward will be shared after the call. And please keep the resources, your data, and your reports coming in even post-meeting, because they can be added. So do check the All ROHCT community. I believe that's where Francis is going to put it in. Open Communities is a great space to post and search for resources and connections with others in the field. In the chat box, the Open Communities Platform Guide, I believe, has already been, the link has already been shared there in the chat box. The final Open and CareQuest Institute Learning Community will be next week on Wednesday, December 13th. And that registration link is in the chat box. I saw it just a moment ago. Open will be meeting in person at the National Oral Health Conference in St. Louis on Sunday, April 14th. So we hope to see you all there. And again, we want to wish many thanks to our wonderful presenters from today. And thank you all for keeping this work moving forward. It was great information. I took tons of notes. And I look forward to seeing the notes and everything, and those resource links and everything being added to communities so we can retrieve them there as well. So thank you again for everyone joining us today. And I wish you all a very happy holiday season. Be safe and be healthy. And thank you again for your time today. Oh, and don't forget the survey. I forgot the survey. There's a survey. And I believe that link has been in the chat box as well. So don't forget to fill out the survey, please. Did I forget anything, Francis?
That was yeah.
Okay, thank you. Don't forget the survey, you guys. Thank you.
Thanks, everybody. Bye-bye.
Bye-bye.